We will start. Good morning, everybody. Bright and early. Sorry for the sniffling, the allergies. My meds haven't kicked in quite yet. What I was going to do is go through a laryngology case for general oral boards type style. So what I was hoping we could be able to do is I'll start with basically whoever's the most junior. So it will be on your honor that if you're an intern or a PGY2 to answer first. And then, you know, as the case goes on, then we'll have more and more senior people. I'll be asking them what they think. So it's just gonna be a case. We'll figure out how this goes. Okie dokie. So a 27-year-old woman presents with a chief complaint of dysphonia. Sorry, that really threw me off because I just misspoke entirely. Dyspnea. It's a dyspnea case, airway case, sorry. So she has chief complaint of dyspnea. And so if you are a intern PGY2, unmute yourself and tell me what you want to know from a history standpoint. And if that doesn't work, then we can chat. So 27-year-old chief complaint of dyspnea. What do you want to know from the history of present illness?
Kate, July, why don't you take this?
Sorry, can you repeat the question again?
Yeah, no problem. So it's a 27-year-old woman. She comes into the office with a chief complaint of dyspnea. What do you want to know?
How long it's been going on for?
She says it's been for about a year.
Does it get worse with any sort of positioning or any sort of activity?
Pretty minimal activity. She can walk about 10 yards or so on a flat surface and then needs to take a break.
Any recent surgical procedures or intubations?
No.
Any difficulty with voicing?
Voice is normal.
History of tobacco use, difficulty swallowing?
No, she's not a smoker and did not have any trouble with swallowing.
Any other medical comorbidities or medications that she's on?
She has exercise-induced asthma that was diagnosed sometime as a kid. And she is only on a steroid inhaler with a long-acting bronchodilator in it, and then takes 20 milligrams of omeprazole a day.
Does it occur all the time?
She said pretty much. It was a slower onset, you know, about a year ago, but it's been pretty consistent over the last couple of weeks to a month or so. And just getting to the point that, again, she can only walk a few yards before feeling like she needs to take a break.
Well, I do probably physical exam at this time.
Okay, I'm going to go ahead and give you some more information on the history. So the other things that you want to ask are like some specifics in regard to what you think could be contributing to it or could not be contributing to it, as far as kind of when you're thinking through your differential. So well, let's just go with that. So and I see the chat room's up, so Kate, maybe you're off the hook. What are some thoughts that you might have at this point? And so this is a broad differential when you've just done a history, you know. So what do you think could be causing her shortness of breath? Kate, you're welcome to continue to throw things up, but this is not on you the whole time. Yes, so autoimmune disorders. So it could be that she has one, that this is causing it, or wanting to know other things. Yes, cardiopulmonary issues. From an autoimmune disorder standpoint specifically, she does not have any family, or she does not have any history of one. Asthma, correct? Idiopathic stenosis, correct? Yeah, because Kate did mention that. So she doesn't have any recent intubation. So you wouldn't think that, or trauma. Well, you didn't ask specifically about trauma, but she wasn't in any accidents or anything. So it wouldn't be caused by that. Does she have noisy breathing? Great. Yes, thank you. She feels like it's hard to get air in and out. And it does have a little bit of a noise to it. She can't really describe it though. And when we get to the physical, I'll try to describe that part. And so other things that we think of in the laryngology world would be like PVFM or intermittent laryngeal obstruction, however you want to call it. Vocable paralysis. Sure. Yeah, it could be that. It's a pretty good one. Okay, so I'll go and give you the rest of the history that that I got from her. So feels like it's hard to get air in and out. She's frequently clearing her throat and feels like there's kind of mucus stuck in there. And then periodically she has to like breathe funny to get it to move because she feels like that she suddenly can't breathe. But it's not, she doesn't have any actual cough or like chest symptoms. No bleeding. Her inhalers that she used for her asthma used to help, but no longer do. So like a year ago when this was starting, that was kind of helpful, but not anymore. And she has, we did the no voice changes, no dysphagia, we got that. 6 to 7 pound recent weight loss. And she does have regular heartburn and reflux, no history of traumatic intubation or prolonged intubation. And then she denies rashes, joint swelling, or rheumatologic complaints. From a surgical history standpoint, she had her adenoids out at age 12 and wisdom teeth were recently taken out, which she wasn't intubated for. And she's got no allergies. We discussed her medications, which are, I'll just type them in here just so everybody has handy. And PPI, just over the counter. No allergies to anything. She's not a smoker. Drinks alcohol like socially on the weekends kind of thing. No drug use. She's a lawyer. Family history is significant for her mom has diabetes and pancreatic cancer and a grandparent. Okay, so everyone, you always have to ask, you want a complete review of systems. Hers was negative, but just, I won't belabor that. But when you do your oral boards, you do need to ask those things. And then, okay, so we're going to start with physical exam. So as far as, yeah, we can do whoever's, let's just do the chat. I mean, if you want to, if you're on and you want to unmute yourself, then by all means. But the chat seems to be working pretty well too. So what do you want to know specifically on your physical exam? So you need to ask, you want a complete head and neck exam, but then somebody's going to say, okay, well, what's that? So what do you want to know? MPT. I don't know what MPT is. Ah, nice. It's normal. Vocal tasks. So yeah, so she is speaking normally, normal volume, normal voice quality. Good. So she does have some noisy breathing that is biphasic, mostly inspiratory, but a little bit expiratory. And you can really only hear it with a more rapid inspiration. And it sounds kind of, it's not the stridor like a kind, but sorry, excuse me, rather like a Darth Vader kind of sort of sound. So it's kind of a rough quality to it. as opposed to sounding vocal like a true strider. Neck masses, no neck masses. Increased work of breathing. She seems pretty comfortable with it actually, but I didn't have her get up and walk around. She does have a normal nasal exam. Vitals, yes. She's afebrile. Her blood pressure is 119/81. Heart rate's 99, respiration 17. She's satting 96% on room air, and she weighs about 110 pounds. She's a little bitty thing. Cranial nerves are all normal. NPL, are you asking for a laryngoscopy? Yes, perfect. Okay. So yes, at this point, this is now just for your edification, from a billing standpoint, you have to say that you tried a mirror exam and it was ineffective due to a gag reflex, just so you know. If she had voice complaints, we would do a stroboscopy, but she doesn't, and her voice quality when we're listening is pretty much normal. So, so we will do a flex halogen. So now I will share my screen. Okie dokie. So I'm just going to play this and then we'll go from there. All right. Love it. Subglottic stenosis. Great. Let's back up just a little bit, and you want to describe what you see on the flexible laryngoscopy. So mucosa, vocal fold mobility, vocal fold structures. Are there any lumps or bumps? What's her swallowing look like? Things like that. Possible left vocal fold, something. Nodules come in pairs. Can't be one nodule. Oops, I meant to share again. So, just for the sake of things, we'll review it one more time. Which I mean probably that, which is probably a little mucus. So yes, in the immediate subglottis, so she's got normal vocal fold mobility. These little bands here are starting probably about, I don't know, 5 millimeters to getting close to a centimeter distal to the vocal folds. And then there's an anterior webbing, as well as some posterior that results in a very small pinhole of an airway. Swallowing's normal. And I have a very good speech pathologist that got her view. So it's a circumferential stenosis, and I would estimate, so there's mucus right there, but her airway is probably only a couple of millimeters, something like that. Okie doke. So we'll go back to our chat. So yes, so subglottic stenosis, but what are your thoughts as far as causes for it, and what do you want to do now? What's your differential? So subglottic stenosis, there's idiopathic, which is possible. Yes, Wegener's, good, thank you. Any other autoimmune or inflammatory things? Amyloid, sarcoid, good. Polychondritis. So if you were thinking that, then we would, so yes, it's possible. But at this point, with a normal nasal exam and normal ears as well, then it would be a little bit less likely, just from a history standpoint. But sure, it's possible. There are a couple of infections that can result in this, so so that you're aware. TB can then result in stenosis, as well as a fungal infection, like blastomycosis or something like that. So again, when you're handing out your differential in your oral boards, you want to say things like, you throw out 3 to 5 real possibilities, and then briefly say, it could be malignancy, right? It could be cancer, unlikely, based on mucosal appearance, and her history, age, lack of risk factors, things like that. But it's possible. Things like a low-grade chondrosarcoma, something like that. It doesn't really look like that, but so you want your examiner to know that you're thinking of a handful of things, what's likely and what's unlikely, and then you would say, yes, it's most likely a stenosis, possible autoimmune or inflammatory, versus acquired is less likely due to her lack of prolonged intubation. But, again, possible things like that. So good. Okay. So now what do you want to do? What are your next steps with her? PFTs. Cool. Yeah, you could get PFTs. Hers shows an expiratory loop, whatever. I didn't get PFTs. She didn't come in with them from the outside. Micro-DL, CO2 laser, balloon dilation. Cool. Yes, we will talk about operative management. I'll be more specific. Any labs you want to get? If you think that she's got Wegener's and Inca, yeah, good. And ANA, perfect. Hers were normal. Any other imaging you want to get? But some people would say that you could get a CT of the neck, but I would actually argue against that. So, okie dokie. So micro-DL, CO2 laser, balloon dilation. How do you want to approach this? So yes, you need to take her to the operating room. What's your timing, do you think, for it? Very soon, not urgent, giving, yes, exactly. So within a week or so, yeah, these are challenging in regard to, you know, your timing of it. Because on the one hand, it's, you know, been slowly progressive, but on the other hand, she described apparently, you know, basically having mucus plugs to that little pinhole periodically. So, you know, feels like she all of a sudden can't breathe, has to like breathe funny or get it to move, like a quick inhale or try and force some air out. So she's somebody I'd probably say, you know, within like 24 hours or so. So actually, I can't remember if I admitted her, we just did it the next day, but nevertheless, we took her to the operating room the next day. How do you want to counsel her in regard to what your plan is? So, and well, no, actually on the chat, it should be fine. So you want to, how do you want to counsel her in regard to risks? Yep, possible trach, absolutely. Every airway case, that's always a possibility. I personally tell folks that, you know, sometimes it's a real possibility. Prolonged hypoxia, yes, multiple procedures, absolutely. Maybe lifelong, need for more procedures, possible need to stay intubated, good. For suspension microdirect laryngoscopy, always a damage to lips, teeth, or gums, change in taste or tongue numbness from the suspension. She doesn't have dysphonia now, but if the scar progresses or you screw up during surgery, they can have voice changes. You can have scarring of the vocal folds, whether it's a mobility issue, because the band kind of goes up towards the vocal process and prevents mobility, or you can actually lacerate the vocal folds with your laryngoscope or a balloon or a laser. So dysphonia is a possibility. What do you want to tell them about risks of using a laser? Airway fire, couple more. Yep, external burns, damage to the eyes, damage to the skin. How do you want to, ideally, how do you want to ventilate her during the case? Jet, What are the risks of jet ventilation? Pneumothorax, correct. When you're also, yeah, and high CO2 retention, but that's fixable. But yeah, so pneumothorax is a possibility. With dilating the airway, whether it's using a laser or anything else, there's also damage or risk of pneumomediastinum. So keep that in mind in telling patients. But yes, pneumothorax with jet ventilation and just needing to dilate. What do you want to do during the surgery as far as, well, I'll just ask. You don't have to biopsy it, but if you wanted to confirm things or the patient needs to know, then you can do that. What else do you want to do during surgery? So you want to use a laser to make cuts, and I think somebody said already, well, we've already discussed, yes, balloon dilation, or you can use Jackson dilators, steroid injection. Yes, I would do that. Personally, I also use mitomycin C. We don't have to get into the weeds of that unless somebody wants to later. lifelong. Okay, good. So I think we got through all that. Okay, so now let me pull up her. I just have still pictures of her case, before and after sort of thing. So I will share. So this is what she looked like before. So here's left vocal fold, right vocal fold, and here's her stenosis. And she actually, this isn't the best picture, had this cool little, like, there was one lumen there, and then she also had this tiny little pinhole there. So it's pretty interesting, hence why I kept the case. And then her post-op. Oops. Looked like that. So there's normal distal trachea, still has a little bit of some thin webbing there, but the dark stuff is from the laser. So yes, we used a CO2 laser, made a couple of cuts, and then balloon dilated and injected steroids circumferentially, and applied mitomycin C. So when you're using the laser, in these cases, it's hard because normally you would talk about kind of saving healthy mucosa, but with her having only a little tiny pinhole, then your diameter of that's really not much. See if I can pull up the chat. Could do KTP. Yes, you can use a KTP laser for it if you want. I personally use CO2 lasers for this. Some people, you can also use just a sickle knife. You can use cold instrumentation for it as well. I think that the main thing to keep in mind in this sort of stuff is using what you're comfortable with and what you're used to. So from an instrumentation standpoint, you know, yes, if it's CO2 or KTP, whatever, but just being comfortable with how you're using your instrument. Okie dokie. What do we have next? Okay, so we jetted throughout the case. She didn't ever have to be intubated, but sometimes folks do periodically if you're having adequate chest rise due to their body habitus, or if they do have bad asthma or COPD and their lung compliance is crappy. But she did fine. She started on 100% SATs and then stayed in the high 90s. And at the end of the case, we just woke her up on a mask. So she goes to the recovery room, and she's moving air much more easily. She is like happy as a clam. But then the anesthesiologist calls you because her SATs will not go above the low 90s on room air. What do you want to do? Chest x-ray, yes. I would also go see her, but you know, they could also be getting a chest x-ray. So when you go look at her and talk to her, she looks comfortable. She's a little bit tachypnic, breathing in the mid-20s as far as rate. She feels a lot less short of breath than she was beforehand. You feel on her neck, she does not have any crepitus. Her breath sounds are equal bilaterally when you listen. And then yes, you do get a chest x-ray. And let's pull that up. I will share this. Somebody want to describe the chest x-ray? I'll share it again. Increased interstitial infiltrates. Yeah, a little bit. There's more. Left apical pneumo. Good. Yes. There's actually a teeny tiny one on the right side too. But yeah, she's got this apical pneumo right. Yeah, it's a pretty decent one. So you call CT surgery and they put in a chest tube on the left. They didn't think that the right one needed it. What else do you want to do? At this point, sorry, I guess I'm just looking for imaging. So after chest tubes, you do get a CT neck and chest without contrast because you need to look and make sure that there isn't any air in the mediastinum. I mean, her mediastinum looks fine here, but there could be a little bit because you've got two options in regard to how this happened. It can be from jet ventilation as well as a tear in their neck from the dilation. So she could have a pinhole leak somewhere up there, and so you need to check for that. Okie dokie. So she got admitted, chest tubes, home in a couple days, everything went fine. So then what would you want to send her home on, or what do you want to do as far as kind of long term? PPIs, yes. So I usually would keep folks on PPIs for about 6 weeks, even if they don't have reflux, but she's having symptomatic heartburn. So I would keep her on PPIs long term and then have her see GI or do a T&E myself, one or the other. When do you want to see her back in the office? Two weeks. Yeah. I usually see folks back a week later, but week 2. Yeah. Something like that. One thing is just to check on them with her. You want to make sure she's, keep a close eye on her in regard to just whenever there's complications, you want to stay very involved. And then also if you are going to use mitomycin C, they can have a reaction to it. So you want to make sure that there isn't reaction in the mucosa with a lot of crusting usually is what you see, and then you need to suction it out and stuff like that. So bronch in clinic, basically. All right, so let's talk a little bit about idiopathic subglottic stenosis. So if you did biopsy the mucosa and the tissue from her subglottis, then they wouldn't have seen any sort of granulomatous change or inflammation. What is the recurrence rate for idiopathic subglottic stenosis? Ballpark. How often do you want to tell her that she's probably going to have to go to the operating room? It's another way of thinking about it. Based on symptoms, every 6 to 8 months or 6 to 18 months, yes. So yes, it does depend on their symptoms, which makes it challenging, obviously, because if somebody's got other comorbidities or they're overweight or things like that, then their relative dyspnea may be more. But it's usually a little bit over a year, at least that's our current data. So about every 12 to 15 months needing to be dilated again. What are some things that you could tell her you can try to do to prolong time between surgeries? In-office steroid injection, yes. There's also another basically post-operative management. So what are some things you could send her home on from surgery on that may increase your time? An inhaled steroid, good. Couple more. PPIs, I'm thinking of 2 more. Ciprodex, yeah, you could do an inhaled Ciprodex solution. Can also do, well, I would do oral steroids anyway, a short course, just like a Medrol dose pack, or you can do a little bit higher prednisone. And yes, antibiotics that can decrease inflammation, or colonization. So Bactrim for 2 weeks is also a possibility. As far as the steroid injections go, I mean, this is an evolving thing, but I usually do 1 a month, starting a month after surgery, for 3. So that would be a total of 4. Good. So over time, she says that she's, just gets tired of having to have this done all the time. So what could you offer her? Right. Yeah, absolutely. Say, well, that's that thing. What besides a trach? A T-tube? Yeah, T-tube is an option. The risk with that would be the location close to the vocal folds. So the higher the T-tube gets to the vocal folds and their mobility, then that's going to rub infracortally and then probably cause granulation. So with her, it's a little close to the vocal fold, so T-tube may not be the best one. But yeah, somebody that's got acquired stenosis and it's a little bit lower down, that's a great thing to offer somebody. What else? Cricotracheal resection, absolutely. They're a little bit less needed these days with everything else that we have for to prolong time between surgeries, but cricotracheal resection is also an option. How do you want to counsel them in regard to risks? Risks of cricotracheal resection are not to be ignored. So there's a couple things. Zoffer's risk, albeit lower. Dysphagia, dysphonia, vocal fold paralysis. Yes, vocal fold paralysis. Also with the location that this is, as far as at the cricoid level, just having stenosis and joint fixation. So vocal fold mobility changes, whether it's a nerve paralysis, because the recurrence are there obviously, or from stenosis. Need for a trach, absolutely. And that could be potentially long-term. Mediastinitis, yes. With women, you're dividing their cricothyroid muscle. And so that can, when you're doing a true cricotracheal resection, which is what her case would be. And so Some women, if it matters to them, they're going to drop about an octave, probably is in regard to pitch. So some people may not care. Some people that could be a big issue. So needing to tell them that. And the fact that it can still come back. Yeah, so still carries the risk of recurrence, albeit lower. Good. And so some folks need to be dilated or have steroid injections and all these sorts of things later. So you, in the end, may not be giving them tons more time or that sort of thing. There are also folks in, where are they? Cleveland Clinic, sorry, that are doing basically carving everything out and then doing a skin graft and putting that in, but that requires, also carries risks. So that's kind of a newer development surgically. Well, good. So that was just the case that I wanted to take y'all through and kind of be thinking about how you do approach oral boards. At this point, I'm just happy to take any questions folks have. You are very welcome. Hopefully that was somewhat useful. I'll hang out on here for, you know, another few minutes or whatever. Hi, Sarah. Good morning. Do I use jet ventilation for most of the MDL cases? For airway cases, yes, I jet pretty much the entire time. We can also, we've started using high flow nasal cannula oxygen. That's also showing some promise. And I mean, honestly, it's just another option. So it's not that if you start with high flow and then you need to jet them a few times that you know you failed or anything like that. It's just a nice additional tool that you have. Time of inflation with balloons. Oh, sorry, so we're still back to jets. And periodically intubating patients only if their SATs are dropping, you know, into the 80s or so. And then having the tube in until they crank back up. And then I do not wake them up with a tube. I mean, if you can mask them going to sleep, then you can mask them waking up, but I try and avoid, particularly after mitomycin C being in their tubes, you know, sitting against that. And so you can wake them up on a mask or an LMA. Which airway balloon size to use, and does length of time and inflation really matter? So 14s are kind of my go-to, 14 millimeter balloon. If that keeps watermelon seeding and slipping past it, then you can start with a 12 and then sometimes go up to a 16 depending on the size of their trachea. But usually it's a 14, and oddly enough, like if you dilate for, I usually try and hold for about a minute, which is usually about how long their SATs will maintain, and then take it down, and then you can use the same, and then breathe them back up, you know, jet a few times. And then you can use the same balloon a second time and get a little bit better dilation. I don't really understand that, but it happens. If you're using an acclarant balloon, be aware that you can't pull on that. Like if it's starting to watermelon seed while it's inflated, you can't pull back on it because it's going to take off the tubing that deflates the balloon, and then you've got an obstructive airway foreign body, so you need to be able to pop the balloon. The new Aeris balloons don't do that, and they're cheaper. But and the time, does the length of time of inflation really matter? I don't know, because I feel like, I mean, if somebody's sats are maintaining, I'll leave the balloon in for, like a minute and a half or something like that. And then again, you can do it a couple of times. So I'm not sure how much it does matter. And my choice of laryngoscope, the big laser Dido or the Ossoff Carlin is my my go-to. And Ossoff pilling is also very good for this. If somebody's got an anterior larynx or a small oral cavity or mandible size and the Dido is just not going to fit, and Ossoff pilling is good for this. If they're a tall person and it's a little bit distal, then the extended length Ossoff pilling is also very good. And then you can also use a subglottoscope. The subglottoscopes have a jet port for the needle, which is handy, as well as suction for the smoke. But it's a little bit, the subglottoscope is narrower at the distal end. So I prefer basically as much room as possible, which is going to be a Dido. You can also use the Zytel scopes. You are very welcome. I'll hang out just another minute or two in case anybody has other lingering questions, and then we'll take a few minutes before the 9 a.m.
Yep, it's good. Okay. Can you see me advancing? Yep. Okay, so again, let me know if there's any problems. So yesterday, Dr.
You can see the screen. Nikki, can you at least see it? I want to just make sure you can see it since we're on record.
Yeah, I can see it.
Very good. If anyone has any problems, I'm still kind of a freshman.
And everyone can see my notes. That's good. All right. So tobacco and alcohol. Again, the alcohol is probably not the major contributor.
All right, well, I apologize for being a little bit late, guys. There was some technical difficulties with.
I am hopping off. Y'all enjoy the rest of your day.